Our nursing problem is about the concern for those patients who ended up with ventilator-associated pneumonia 48 to 72 hours after endotracheal intubation. The research we looked into had to do a lot with the different types of oral care that would prevent pneumonia in these certain patients. In each article that we found, it brought up frequency of oral care that should be provided and the different solutions and methods used as part of the oral care regimen. This problem is very important to us because there are so many patients in the ICU who are getting ventilator-associated pneumonia in over half the cases, leading to high risk in mortality and morbidity. This is something that we as nurses can prevent from happening frequently in the ICU. So our PICO question is, does oral care reduce the risk of ventilator-associated pneumonia in critically ill patients in the intensive care unit? So our P, the patient or problem, is the critically ill patients that are on ventilators in the ICU. Our I, which is our intervention, is oral care that's given. Our C, which is the comparison, no oral care given to the patient. O, which is the outcome, is a decrease in ventilator-associated pneumonia. For our literature search, the main databases that we used were CNOL, ERIC, Medline, PubMed, and ProQuest, all through the Abisco search engine. Our main keywords that we used for our articles were ventilator-associated pneumonia, intensive care unit, oral care, and critically ill patients. However, each of us kind of used alternative wordings and abbreviations. The limits that were applied to our search engines were 5-year limit from 2010 to 2015, English language, any nurse as an author, and peer-reviewed articles. The number of searches, or the number of articles retrieved from each search varied. Like I retrieved about 20 articles, while others retrieved anywhere between 50 to 100 articles. Each person's view made a difference on the number of articles that were eliminated, flagged, and pulled out based on the relevance of the problem or the PICO question. As you read, you will notice that our main interest was finding studies that focused on the involvement of nursing interventions and the different types of oral care that was provided to the patients who were ventilated, like the use of Listerine in the study conducted by Barry and to the use of chlorhexidine solutions in several of the other studies, while the study conducted by Alejandro and colleagues focused on the use of VAP prevention bundles.
From all the studies that were appraised, the outcomes of the studies were different from one another because some of the studies focused on the implementation of oral care hygiene and VAP bundles, while other studies focused on nurses providing oral care to their patients. One study conducted by Oroglia and colleagues found that adherence with a ventilator bundle was 92% during the study. However, when the respiratory therapist took over oral care, the adherence improved from 33% from before the study to 97% after the study. A couple of studies showed that providing toothbrushing and not providing toothbrushing showed no difference, and that electric and manual toothbrushing had the same outcomes. As for usage of solutions, such as povidone iodine and chlorhexidine gluconate, showed mixed findings. One study showed that povidone iodine was more effective in reducing VAP than saline solution, while in other study showed that the povidone iodine was weak in comparison to saline, while 2 other studies showed that chlorhexidine reduced VAP. There were 2 other articles that caught our eyes about nurses being involved in the care. One study conducted by Filer and her colleagues showed that oral care policies are present but are not used well. Nurses are not aware of the published guidelines, and current oral care practice does not meet evidence-based practice recommendations. The other study showed that after implementing practices related to ventilator tubing position, sedation management, oral care, head of bed elevation, and hand hygiene, VAP rates in ICU dramatically decreased. The oral care approach implemented was the use of an oral care kit with cyanopyridium antiseptic rinse agent with both a toothbrush every 4 hours. And this decreased VAP rates and extended the length of time between VAP cases. As you can see, we had a variety of different articles that were very influential in our research projects. Majority of the studies that were conducted made a difference, while others showed no difference between interventions that were provided to patients.
Now I'm going to talk about an appraisal that was done by Angela Berry. This study compared Listerine and sodium bicarbonate oral solutions in reduction of ventilator-associated pneumonia. The purpose of this study was to see if using Listerine or sodium bicarbonate solutions worked better in reducing the dental plaque that contributes to ventilator-associated pneumonia. Ventilator-associated pneumonia is associated with significant morbidity and mortality. The reduction in growth of dental plaque with respiratory pathogens may reduce the incidence of ventilator-associated pneumonia. Oral hygiene is an important nursing activity and, if based on sound evidence, has the potential to reduce bacterial growth of dental plaque. One of the main reasons poor oral hygiene occurs is because access to the mouth is limited due to endotracheal tubes. Patients may become agitated during the cleaning, and therefore nurses will not do cleaning in order to just not disturb the patient. This sample was obtained using a randomized control method. The patients had to be admitted to the ICU, intubated, and over the age of 15. Inclusion criteria included that the admission had to be within 12 hours of intubation and on the ICU floor. Exclusion criteria used was patients diagnosed with autoimmune disease, previous admit to the ICU, and those requiring specific oral care due to facial trauma, facial surgery, or receiving chemotherapy. 398 people were randomized to a group, a Listerine group, a sodium bicarbonate group, or a control group where they received sterile water. Each group received these rinses twice a day, along with having their teeth brushed with a soft toothbrush 3 times a day. 45 of these patients were not eligible for this study. Methods used to collect the data included a microbiological sample that was taken from the surfaces of the top and bottom teeth, as well as the gums. These samples were tested for bacterial growth. A daily chest x-ray was also taken and reviewed by a radiologist. The radiologist was not aware of what kind of oral care the patients were receiving. The intervention tested was the sodium bicarbonate, the Listerine, sterile water. Each group received toothbrushing with a soft bristle toothbrush and a general purpose toothpaste. Nurses were given a detailed instruction on how to provide the oral care. They had to brush the gums, all surfaces of the teeth, the tongue, and use oral irrigation and suction. Nurses were also trained on how to collect the specimens from the mouth to be tested. Sample size was determined using power calculation with alpha equaling 0.05 and beta equaling 0.8. Patients were randomly assigned to these treatment groups. Nurses did not know what kind of treatment the patient was receiving until opening up their oral care packs, which contained the different solutions. The main finding was the importance of mechanically brushing a patient's teeth with a soft toothbrush. Out of the solutions, Listerine, sodium bicarbonate, and sterile water, there was not one solution that was significantly better than the other. Compared to other studies where toothbrushing was not used, using a toothbrush showed that the benefit of using one is greater. More studies need to be done to determine if different types of brushing work better in preventing ventilator-associated pneumonia. Ventilator-associated pneumonia was diagnosed in 18 patients. The incidence in the sodium bicarbonate group was 4.5%, the Listerine group 4.7%, and the control group, which was the sterile water, 4.3%. This research occurred over a 2.5-year period. Comparisons were done for cultures of dental plaque growth on day 1 and day 4 to test not only additional growth, but if it was equal. The study was published that required a peer review. The design was appropriate to the research question, and the data obtained and the analysis conducted did answer the research question. The measuring instruments were reliable and valid because they used chest x-rays that were reviewed by a radiologist and lab results from the dental plaque. The extraneous variables and bias were controlled. This was a double-blind study. The patients did not know what type of oral care they were receiving, as well as the nurses. The study was free of extraneous variables. The participants were randomly assigned to groups, and they were similar in that they each received the oral care with toothbrushing 3 times a day. Just the only difference was the solutions that were used for the rinse. The interventions were well defined and consistently delivered. The nurses had to learn exactly how to brush the teeth and how to use the oral rinses as well as the suctioning. They also were trained on how to collect the data for the specimens. The groups were treated equally other than the difference in the interventions due to the different solutions. And the findings were consistent with other studies because previous studies showed that there was not a significant increase depending on the type of solution. The only difference with this study was the toothbrushing 3 times a day.
From the articles that we read, we learned that patients on ventilators who received oral hygiene reduced the risk of developing VAP than those who did not receive any type of oral care. However, there is no difference found based on the type of oral care that was provided, such as the use of toothbrushing, powered brushing, use of swabs, chlorhexidine rinses, saline rinses, and povidone iodine rinses. The majority of studies that we looked at showed a reduction in VAP with the use of chlorhexidine rinse or gel. However, there is no difference found with the use of toothbrushing or manual brushing and swabs. One of the biggest issues was that nurses did not implement oral care to ventilated patients as they should be. On the study conducted by Gans and colleagues, it showed that nurses rated oral care a priority but did not implement the latest evidence-based practice.
We would disseminate the information about our research to the nurses on the ICU units by having academic presentations and workshops where we would go over the research and findings of types of oral care that can be given to the ventilated patients and their effectiveness. At the end, we would have a workshop showing the nurses how to effectively perform oral care and have a friendly competition giving care to civilians. Other options would be to have flyers around the nurses' station, staff lounge, and bulletin boards throughout the unit. We've come up with a way to implement our research findings. One of it is a mandatory check-off or a sign-off sheet in each patient's room who are on ventilators. With this, each time the nurse enters the room, she or he must sign or check off a sheet each time oral care is given to the patient. So they would have to sign their initials, date, and time. We've come to the conclusion that more research is needed on this problem. As of right now, oral care is not consistent or standardized in the ICUs of most hospitals. We believe that a randomized control experimental study needs to be done on the effects of different types of oral care provided to the ventilated patients and the frequency of implementation of the care. On the other hand, there should be a descriptive study on oral care practices given to ventilated patients by the ICU nurses using evidence-based practice. In conclusion, proper oral care in ventilated patients can help reduce ventilator-associated pneumonia. However, oral care is not consistent nor standardized in the ICUs of most hospitals. Oral care is simple and effective strategy to reduce ventilator-associated pneumonia in patients requiring mechanical ventilation. A few ways of combating this development of infection is by using chlorhexidine rinses, manual toothbrushing, or tooth swabs. Through our research, we found that providing oral care to patients on ventilators is clinically significant, but not statistically significant. There were no signs of significant differences in benefits from the use of different oral care given to the patients. But in the end, there were some reduction in developing ventilator-associated pneumonia. Nurses should provide oral care at a minimum of 3 times a day. Therefore, providing oral care hygiene is still important for ventilated patients in clinical settings.
Accio toothpaste! Ta-da!